read articles about initial bond strengths for different bonding agents, I think that's a misleading. It's a misleading data set, because in reality, how strong something is on day one is irrelevant to how strong it is on day 100, day 500, so on and so forth. And not the literature, but the advertising of all of the companies are very aware that if they advertised their bond degradation over time, we probably would still be placing amalgam. Initial bond strength is a very important part of this conversation. Well, if we're going to bond, which bonding protocol are we going to use? We're going to use total etch, self-etching, universal, so on and so forth. Do we need to chemically bond to the post itself? Are we trying to actually glue it to the walls? Or do we want to make Todd's life a lot easier and have it be luted so it's easier to remove if and when retreatment needs to happen? Are some post cements better than others? Are some posts better than others? And how do we take all of these potential variables and give the patients the best science has to offer? So it's these questions that ruminate through my head on a daily basis when it comes to posts. And as I've had these conversations with the doctors in the practice that come from different educational institutions, there seems to be quite a bit of confusion when it comes to posts. So I was pretty excited to put this presentation together. I'm really interested to hear what others have to say. Please understand, there is no right way or wrong way to do this stuff. But I think there's certain fundamental principles that I think will at least tilt the scales in our favor to making sure the patients have the best care possible. So a few pre-discussion considerations. These are just things that I think we should kind of get out on the table. Number one, bonding to dentin is not the same as enamel. I think we can all agree to that. Also, dentin varies greatly as we progress from the pulp chamber to the apex. So there's a variability in the character of dentin as we progress down, and that's an important consideration as we make decisions with posts. So in my literature review, this is probably the third time I've kind of gone into the accessible literature online, drawing some conclusions as I'm doing it, as I'm trying to learn this stuff just like anybody else. I have several textbooks on restorative dentistry that summarize the literature, but they're somewhat outdated. But it's pretty clear that it's very difficult to draw conclusions on post and clinical dentistry due to a variety of factors. The first is a lot of these tests are done outside the mouth. So the whole conversation of how are we able to assess clinical performance if we're measuring it in a non-clinical setting? It's pretty important. Many of the studies have varying methodologies. It's hard to compare apples to oranges because they're not the same. They have different strength testing, different materials are used, different methods. They have different null hypotheses. Many of the studies have commercial support, which really removes the validity of what's being asked and answered. And also, what works in one clinician's hands may not work in another. And I think when it comes to posts, there's so many variables that are involved with the execution to something that looks very simple. I think that's the biggest misconception that I think most restorative dentists have, is that posts look easy, but when we go to do it, for some damn reason, it's so hard. I have yet to meet a dentist, me being one of them, who has ever said posts are easy. Now, there are ways to make them easier and streamline the process, but I think right out of school, it's a challenging part of our restorative practice that we should definitely put some focus on. And then lastly, the 7-minute ab factor. This has to do with advertising. I'm going to play the video first. Let's see if I can do this.
Hey, thanks for picking me up, man.
Yeah, no problem. I've been driving for like 15 hours straight, so I could use the company.
Yeah, I know what you mean. I've been standing in the same spot for 5.5 hours. You know, they made it illegal to hitchhike in this state.
Really? That must make it really tough.
Let's go to the next one. All right. The point of the 7-minute ab factor. Has anybody ever seen that movie, Something About Mary?
Yeah.
the whole point of that skit is the fact that this guy comes up with a brilliant idea, and it's the fact that 8-minute abs is really popular, so I'm going to come up with 7-minute abs. And they do it in a very humorous way. But the point is, in the world of advertising, the race to the bottom is often part of the decision making as companies decide how many steps they're going to involve in the process. And when it comes to posts and cements and composites, companies are always trying to create the 1-step, the 2-step versus the 3 or 4-step. There's always a race to the 7-minute abs, is how I always think of it. In the world of posts, that's very true. And I would say we really have to think through what are we doing and what are we trying to do for the patient so that we can make good decisions. And we really not try to do it in 1 step. So let's break down the steps. We have the post-space preparation, the post-selection, post-space preparation I have twice, bonding methodology, cement selection, the placement protocol, and then other additional considerations. So there's a lot of things to keep track of as we're doing posts in our patients. So the first is following directions. Those that were part of the bonding NECADE session we had back in October, I talked about an article that Jerry Kugel from BU did in Dentistry Today many years ago. And it wasn't an article of scientific quality. It was him just talking. And what he said was, in his 35 years of teaching, he's astounded at how few dentists actually read the directions of the products that they use. And when it comes to composite-based dentistry, I think it's very important. That always stuck with me, and I'm always amazed when I read the directions how even my best of intention clinical execution is actually off a little bit as I read the directions of a new product that I thought was very similar to another product. Point being, read the directions of the products you use. When it comes to posts, there's a very specific sequence that a lot of the post systems have that sometimes involve Gates-Gliddens, for example. Well, if you didn't read the directions and you just open the kit, there's no Gates-Gliddens in there. You just start using the drills and you're wondering why you just went through the side of the tooth. Read the directions. So Gates-Gliddens, in the world of endodontics, I don't know if they're overly relevant. They were very commonly used early on for coronal opening, maybe opening of the coronal third of canals. But what they do for post space is very important. The fact that they keep you centered as you're creating the post space. These have a very specific nature to them that the post drills don't have. The post drills are very stiff. If you apply enough pressure, you can get off track. These are pilot drills, and they're very, very important. There are some systems that don't necessarily require this. I've used some systems that are better than others. I feel better using Gates-Gliddens. So what I would recommend is that while you're getting really good at post spaces, even if the system doesn't call for Gates-Gliddens, use the Gates-Gliddens. I promise you're going to feel a lot safer if you go from the single one on the left, which is the smallest diameter, all the way up to, say, the 3, 4, or 5, depending upon how big the preparation you're doing is. Todd, you're there. I'd be curious to see what you do a lot of posts. Do you use Gates-Gliddens for this?
That's a good point, Nick. Can you hear me okay?
I can, yep.
I had never really thought about using Gates. I think that's actually a great idea. Generally, when we're preparing a post space, I'm rarely going larger than what I've instrumented the canal to anyway.
Sure.
So the post space that I'm creating is more of a refinement rather than drilling a space.
Sure.
But I do like the idea of the Gates.
Yeah, I guess you bring up a good point that as an endodontist, my thought is you probably do warm vertical, and you probably don't have any gutta percha to get out of the way.
Right.
So
Exactly.
you're only backfilling your apical third, and then you already have your post space.
Exactly.
Right. Yeah, in the Parapost system, they advocate for the use of gates, and I was using ultra dense post system pretty much the first few years of my career, which didn't call, at least at the time, didn't call for gates. And then I went to the Parapost, and I followed all the steps, and I was like, this is so, it's relieving in how easy it is as you're removing the gutta percha if you're not doing the endo at the same point in time, which as restorative dentists oftentimes we're removing a lot of gutta percha to get the post in there. Gates definitely help because they keep you centered. They're training wheels. So I have never gone through the side of a tooth using a gates. I went through the side of one tooth before I used gates, probably why I'm more cautious. So something to consider for sure. Going slow and being methodical is key, in great part because of heat creation. It's pretty hard to get irrigation all the way down into the post space if you're starting to widen this. And what Todd said is very true in the fact that we're going to talk about post selection. We shouldn't be preparing a lot of the root. We should be finding a post that fits well in there that doesn't require a whole lot of removal of tooth structure. With that said, we have to be cognizant of the fact that the PDL, the nerve fibers, the lymphatic system, the blood supply is sitting right here. It's very sensitive to heat changes. So if we're not being cognizant of that, so how do we be careful to not create a whole lot of heat? We go in and out, we use water, we make sure that we remove we'll go over the flute conversation. But the point is, don't just push down and keep pushing until it bottoms out, because the periodontal ligament will suffer some demise as a result of that heat creation. Debris removal. This is EDTA here. This is just a slide the best slide I could find that showed something in between the flutes. This is an endo file, so it's a little bit different, but just use your mind to translate over to a post drill. When you go down into the post space and you come out, you want to remove the stuff that's sitting in the flutes. And I know this sounds very rudimentary. I'm speaking from knowledge of seeing dentists struggle with this particular procedure. This is a big one. When you come out, have it 2x2 with alcohol, have the assistant wipe it, and go back in. You don't necessarily get dentin every single time. You may get a little bit, but look at it each time you take it out. If you take it out, you clean it, and you put it back in, you're not only cleaning the flutes, but you're also making sure that you're not creating too much heat to bother the PDL in the surrounding part of the tooth. Keeping center maintained. I was going to take an image of a tooth that I have. Unfortunately, I got wrapped up into something today. But the point is that as you're removing the gutta percha, again, this is a tooth that's been treated prior to the post space, so there's probably 2 separate appointments. But for those of us who use carrier-based obturation, this is what we have to do. We want to remove the gutta percha, but we're always looking to make sure that the gutta percha is in the center of our post space. Canal anatomy varies, so it's very easy for the canal anatomy to head in a direction that we didn't necessarily anticipate. If you look down and you don't see gutta percha in the center, you're probably off track. At that point, you might want to take a radiograph. There's different ways to do it, but just be cognizant of the fact that that centering of the gutta percha is confirmation that you're staying within the canal. Keep looking for the pink bullseye. So obviously the person that did this came off the internet. If it was mine, I would gladly tell you. But you can see here, at some point, had the person been looking, they would not see gutta percha in the center here. Obviously, this tooth is canted off to the side. I say we all. One of the most challenging things to do in endo is when you rely on the crown, the prosthetic, to dictate how you treat the tooth and not the radiograph. The radiograph is really what you need to be paying attention to. So this endo was done well, but when the post was done, they put it nice and parallel to the crown. My guess is they did this through this bridge. Unfortunately, now there's a defect that requires significant treatment. Point being, this person did not have the pink bullseye in mind when they were doing their post. You don't need to push hard. So just like with endo, when you're pushing vertically, or you're intending to push the file vertically, you're not doing it correctly. Files, endo files, and post space drills are intended to work almost by themselves if they're used properly or using the proper one at the proper point in time. That might be true a little bit more with endo files as they design the helical angles of the flutes. They tend to do a lot of the work on their own. The point is, if you're pushing, it's because you didn't create enough space with your pilot drills. So if you're pushing, it's probably because you're creating a ledge or the canal has started to curve away from you. So you want to be very careful of the fact that when you feel resistance, it's probably because something that you did prior to needs to be modified a little bit more. Appreciate canal and root anatomy. I threw this picture back in there. Take a good look at the x-ray or the CAT scan if you have one, and really think it through before you start doing the post space. If you get really good at this, you can rely on the gates and kind of follow through. You can almost do it just by feel, but I can promise you early on, really thinking through where you are prior to doing it will pay dividends in the long run, so you don't end up like this person here. Use sharp drills. So I did a talk several years ago at the Greater Portland Dental Society, and there was a dentist who came up to me 2 years later, and he goes, "I don't remember anything you said, but I just remember I had to go home and get new parapost drills, and it was the biggest game. He hadn't changed his parapost drills in 20 years. And he wondered why he had such a hard time with posts. I learned that the hard way too. I don't know how I came to the super obvious epiphany that sharp drills means everything. These drills dull pretty fast. They're very similar to implant drills. They probably have somewhere on the order of 10 to 20 uses. After that, you're really starting to have to push. And when you have to push, you create more heat. You run the risk of perforation. You run the risk of necrosis of the periodontal ligament. Be very cognizant of this. I don't know if there's a way other than just tracking the uses to tell how sharp they are. Just add this to your observation as you're using post drills. Ones that are really dull are pretty obvious. If you can't see the paint on the stripes that are on the shaft, it's probably because it's really old. Whereas if you see a brand new parapost drill that has a nice solid coloring around it in the band that indicates what size it is, probably fairly new. I think over time we're going to start tracking the uses so that we have a better sense of how many times they've been used. Know the ideal depths. I think we were all taught somewhere in this area here, 4 to 5 millimeters from the apex, 2/3 down to the apex. To be honest, in the literature, there's so many opinions on how far it should go down. It's pretty clear in the literature that it doesn't matter how far you go down. It's just, you got to go down far enough. This is not doing any good. Whenever I see a post that's short like this, 9 times out of 10, when that post ends somewhere near the crest of bone, there's a fracture there. It's a lever force that the root ends up taking all of the stress, and result is implants are coming. But how far down should you go? I think the endo literature is pretty clear. If you have 4 millimeters of a good apical plug, you have a good seal there. But then you're adding a very nice bonded restoration that's here that really should act as an obturator to the canal system. So how far down to go, Todd? What are your thoughts? What's your take on that topic?
Yeah, so that's a good question, and I kind of agree with the way that you put it. You go down far enough, right?
Right.
I don't get to some of the literature that I've looked at recently. It doesn't seem to matter. Length doesn't really seem to matter for retention, and so especially if you're using a fiber post, I don't see the need necessarily to go within that or to that 4 millimeter, within 4 millimeters of the apex. So I wouldn't let that drive where my post ends.
Sure.
It may be a little different with metal posts, and I'm not have to admit I'm not a specialist on posts and materials, and that's why I'm kind of sitting here listening to you. But I think with a metal post, you might be dealing with some different dynamics,
Right.
and so certainly getting that below the crest of the bone and into the maybe the middle third of the root might be a little more important in that case.
Yeah. Yeah, I love what you said, that metal posts, might have different biomechanical requirements. And yeah, I think a lot of the literature that we have for posts comes from that world. And that's why I think there's some new conclusions that could be drawn in the new world of fiber posts. The length of the depth being that. But I think if you can get halfway down, I mean, there's some curved roots where that's as far as you're going to get. Those teeth seem to do well, in my opinion. We're bonding at the end of the day. So we're not only relying on mechanical retention, we're relying on, I don't want to say chemical retention, we'll talk about that, but micro-mechanical retention. So know your depths. Make sure that you have well-calibrated x-ray software if you're using digital software. Just know how far you're going down and be somewhat cognizant of making that decision. And then know ideal widths. And I love what Todd just said, that he often doesn't do a whole lot of post-preparation. For those who don't do a whole lot of endo, warm vertical is the process where you burn out an apical plug. Essentially, you fit a master cone and use a hot tip, and you essentially leave this thermoplasticized plug at the apical third or apical quarter of the root. And if you have a good selection of posts, you just fit a post that fits in there fairly well. So the conversation about preparing a space is not really necessary if you already have a good space present, which in Todd's world often is the case. But if you have got a perch that goes all the way to the top, you have to remove it, and that's where that Gates-Glidden conversation came from. But this slide talked about the width, and I think it's important to know that the wider we get, the more likely we are to fracture that tooth. I think we can all see in our mind's eye that this tooth is more likely to fracture than this guy. Well, this post, cemented with state-of-the-art cementing protocols, in my opinion, is going to fare just as well as retention with a post here. In other words, wider isn't better. If you need it wide to retain the core, maybe that's part of the conversation. You're putting something in there to grab a hold of the root and have it stick out. Whether it's a size 3, a size 4, a size 5. I've never had a fiber post break. Can that happen? Maybe. But at the end of the day, be very selective in how much tooth structure you take away. So know your ideal widths. And another part of the conversation that Todd and I were just having is, if you go too deep, you do run the risk of perforating through the side in very thin roots. So there are certain teeth that it makes sense to actually not go that deep. Lower incisors being very, very common teeth for what we call strip perforations. A strip perforation would be, you're doing your endo, and the wall of the tooth is so thin that you end up creating a communication between the PDL and the inside of the root canal system. So I once had a lower incisor, a 20 file. I had a strip perforation. Well, you can imagine if I did that with a 20 file, what do you think the odds of putting a large post in would be? These things exist, and it's very important that we understand the canal and tooth anatomy that we're working on at that point in time, because we can't see this stuff. We're working in our mind's eye a lot of the time. So we have to have as much information as we can to make good decisions as we move forward. The point of this slide is know your widths. Don't go wider than you need to. So what about post selection? This is the Parapost kit. This is currently the one that we have in the office. Actually, this is the Parapost XT, which is the metal kit. We use their Taper Lux, which I think is their best fiber system. What prompted this conversation is actually, I'm trying to simplify this process, and I think there's some companies out there with simplified drills, and I'd be curious to see if there's anybody out there that has some insight maybe on the 3M kit, which only has 3 drills, I think. I want to make this as simple as possible so that people have predictable clinical outcomes without a whole lot of complexity. But the point of this slide is you need to make sure that the post is big enough. Obviously, this post in this cartoon here, if it was actually the post selected, would be sitting in a sea of cement. Is that good? Is it bad? Cements are meant to flex at the same rate as dentin. I wouldn't be surprised if somebody came out with an article someday that's a scientific article that says, really, it's the cement that's doing the work. The post is just there for retreatability. I would like to have a good fitting post, and I think most people would agree to that. So be very selective of it. This first point here is anecdotal. This is from my world only. I have no scientific evidence here to support this. But I try to select a post that's wide enough that half of the length of the post is touching tooth. So if this was the length of the post, I'd want this post touching at least here down. Because you're not always going to have a post that's tapered. We have taper posts in the office, but many of them are cylindrical. Well, if you're doing a cylindrical post space in a tapered canal system, you're not going to have a post that's engaging 100% of the way. You can get it there, but you're going to sacrifice a lot of dentin down deep. So I do believe tapered posts are better for this purpose. I think cylindrical posts, it's just an old technology. I have yet to see an argument for cylindrical posts in the world of adhesing or cementing fiber posts. But as you're selecting the posts out of all of these options that you have here, each of these colors being a different diameter, you want to engage as much of the canal as you can, but you also want to make sure that you're getting it far enough down that you don't have a space there. Todd could probably indicate whether or not a space that exists between a post and the gutta percha that's underneath from inadequate seating, does that contribute to post-treatment disease? I guess that's a good question, Todd. Do you have any thoughts there? Because I've definitely seen lots of posts that were too big for the canal. They didn't go down all the way, and you just see a gap there. But I haven't seen that lead to a higher incidence of post-treatment disease. Do you have any thoughts there?
I wouldn't think so. If you just, there's no literature to support my thoughts on this, but if we're just looking at a void within the fill material, I don't think that's going to contribute to worse outcomes as long as it's sealed above and below.
Right.
It's just like if you have a composite core and you have a few voids within it, that's not going to be the mode of failure. So I don't get too bent out of shape if I see a void between the post and the gutta percha, as long as we've got a good apical seal apically and a good seal coronally.
Right. Yeah, and I'm glad you said that, because there was definitely a period of time. This is an important point for the associates in our practice that are on this call. We have currently the taper lux from Parapost, which is their tapered fiber post, and then their fiber lux, which is their cylindrical fiber post. Well, if you use the drills from the the tapered kit, but you for some reason end up selecting a fiber cylindrical post from the other kit, it's not going to seat down as far, and you end up getting that gap. So we're going to be replacing these two systems from the office. I had the cylindrical system for a long time because the tapered one hadn't come out yet. That kit stayed in the office, and some of the drills found their way into the other drill kit. I think Colteen Weldent, the manufacturer of Parapost, did a pretty poor job of making the drills almost exactly the same. They probably should have done something different so that offices don't run into this problem. With that said, I think we're going to come up with a solution after this talk. The point being, you got to think through this stuff. It's not as simple as just drill down and then glue in a post. So does anybody have any questions? We're going to talk about bonding in a second. Any questions out there about post preparation?
Hey, Dr. Roy, can I just comment on something?
Yeah, go for it, Luke.
Kind of goes with your directions thing, but also the post stuff. Something I noticed back when I was in school, we did a whole post debate thing, so this came up in it, but the cylindrical pair post versus the taper lux post. I don't know if you've ever noticed the difference on what you're supposed to do when you're supposed to cut one versus the other. The cylindrical ones and the directions they want you to cut the post from the apical portion before you insert it, and the taper lux post wants you to cut the coronal portion and not touch the apical portion when you insert it.
Yeah, yeah, that's why it's important reading the directions. And a cylindrical post doesn't matter which end you cut because it's the same diameter on both ends in theory. I would say it's not
that ball they want on the top. That's why the fiber ones, at least with the ball, they want you to keep the ball.
Right. The newer age fiber posts. So we're going to go over this in a little bit, but I think it's an important point to talk about now. The ball isn't important. We call that macro mechanical retention. The posts have they're treated with I could get into the science of the glass and the filler particles and whether you need a silanate post and all of that. We're not going to go through that. Most of the newer posts have very significant micromechanical retention built into the posts. And as a result, you really just don't need that macromechanical ball. So if you're ever unsure about which end to cut the top end, the side with the ball or the cylinders, because Luke's right. The drills are tapered, therefore the drill has a diameter at the tip that corresponds to the corresponding post. And if you cut the end, because they're tapered, you're going to have a wider diameter. No different than master cones. You wouldn't cut the end of a corresponding master cone and expect it to go down all the way. So yeah, thank you, Luke, for that. And there was another point you had?
No, I'm all set.
Cool. Yeah, thank you for that. It's a very, very good point. What did you guys use at UNE for posts?
Same thing we use at the office, although sometimes Dr. Sure would bring in his own version of a tapered fiber post.
Yeah. What do you guys use, Todd?
We're using, I think we just switched. We're using an Ultradent fiber post, tapered.
Yep.
Yeah.
Yeah, Ultradent. Years ago, I was using their system. I really loved it, and the reason I switched has escaped me. But I think we can all stand behind the fact Ultradent produces great products. So I'll definitely knock on that door too. I was looking at 3M, and I think 3M might be the way we go. Only because it's more simple, not because of the contents of the actual or the materials of the actual post itself.
I got a quick question.
Yeah, go ahead, Chad.
In a tooth that has multiple roots or at least multiple canals, how do you select which canal to place the post in?
Yeah, it's a great question. The easy answer is the straightest canal. That's not always the answer, but if you're dealing with upper molars, that's typically the palatal canal. Lower molars is the distal canal. Those are also the widest. Therefore, you're more likely to not have to remove any tooth structure to get a good sized post in there without a whole lot of reduction. So the straighter the canal, the better. The bigger the canal, the better. Then the question is, do you need multiple posts? If you ask 10 dentists that question, you're going to get 15 opinions. So I'm not going to take a stab at that. I've definitely placed more than one post in teeth that are pretty compromised. Patients that couldn't afford an extraction, and I'm just trying to get them by. I'll put in multiple posts. There's no science behind that I'm aware of. But yeah, straightness and size would be the two main factors that lead to the decision making when it comes to selection of canals.
Thanks.
Yep. All right, so here we have, we're going to start talking about bonding. These slides come from my bonding lecture, so some of it is applicable, some of it's not. It's important to know that not all substrates are created equal. I would feel very comfortable using certain materials to bond a crown on here. I would not use the same materials here, not just because it's leaking, but here we're on dentin. That same kind of rationale holds true. So the materials that we use for post cementation, how we use them and which ones we use may be different than the materials that we use in restorative dentistry for restoring caries. But this all comes back to the 7-minute ab conversation that we were just having, companies are invariably trying to create one-size-fits-all systems because restorative dentists are notoriously likely to choose products that can solve a lot of problems, clinical problems. It's not a secret that many different clinical applications have their own idiosyncrasies that require different materials. But over time, we're trying to find adhesives that treat all of these processes. I mean, literally right now, the universal system is advertised as it bonds to everything, so you can use it for everything. That's very misleading. So we have to be careful when we make decisions on materials and how we use them, and that's what this conversation is about. So here's another. This surface here is very different than this surface here. I would bond to that all day long. I would not bond to that. Let's see how much time we have, because this gets pretty deep. I'm going to skip over this, or at least not go into too much detail. But when we talk about bonding agents, dentin bonding agents in general, we have to understand that these are biphasic molecules, meaning one end is different than the other. Well, composite is a hydrophobic entity, whereas dentin is hydrophilic. Dentin is made of tubules, and what's inside the tubules? Exudate and serum and fluids and water. You know, it's a biological entity. Therefore, it has water. So if we're going to stick something that's wet to something that's not wet and that can't tolerate moisture, we need to have a biphasic coupling agent, which is what dentin bonding agents are. This is important when we talk about bonding posts into the canal spaces, because the dentin, although probably drier, still has tubules that communicate with the PDL and in theory have some moisture associated with them. This is a slide from there, from that lecture. This makes the point that, and I think a lot of us know this, dental adhesion is not a covalent bond. It's not a chemical bond. It's micromechanical retention, no different than Velcro. This has changed since the advent of MDP. We talked about that in the bonding lecture, so I'm not going to dive into that. Point being, we're still relying on micromechanical retention. Why is this important? Because the substrate that we're dealing with comes in many different varieties depending upon how we prepare the post space and what we do thereafter. This is my favorite slide that summarizes all of the different generations of bonding agents. The reason why this is important here is post spaces are very difficult to etch and clean. How do we get down in there and do everything we need to do? And can we do that well? Or do we just kind of throw out the total etch process that we know works really well in the 4th generation and go right to a universal bonding agent, or skip that and go to a self-etch adhesive cement, which is what most dentists do? This is an important conversation to have with it, because the long-term sealability of composite dentistry or adhesive dentistry is very much dependent upon which generation you select. We know the literature is very clear that 7th generation leaks very bad in a short amount of time, which is why we don't use products like G-Bond anymore. It was popular back in the 2000s, and maybe some people still use it, but the literature was pretty clear. This is not the generation to use. Luckily, the universal generation came out to remove that. But you can see here, it's a race towards combining steps. This is the 7-minute abs conversation I was telling you about. There are many clinicians that have very good dentistry that use the 3-step process. I'm still a huge advocate of this. It's still the gold standard in the literature. There's conversations about ways to use 6th generation that have just as good bond strengths. But the universal category, because of the use of the MDP is the only chemical that we have in adhesive dentistry that actually covalently bonds to dentin, or the mineral component of dentin. They're really becoming the mainstay. But how we use these materials in conjunction with our cements is very, very important. And I don't have enough time to dive into it, but I can tell you there are certain bonding agents that don't work well with certain cements. I think we all know that. If you're using 3M Scotch Bond Universal and then you're using Rely X, that's fine. The company made the two products. If you read the directions, there is compatibility there. But if you use Scotch Bond Universal and then for some reason you end up using GSEM from Fuji, I don't know if there's compatibility there. It's very possible that the acidity of those two different compounds are not compatible, and then you end up having a post fallout in a week. Or even worse, it leaks over 2 years period of time, and then you have a recurrent infection, and then Todd has to go in and try to dig out the post that you placed, which will be easily removed because it wasn't tight in the first place. But the point is we're trying to create very good biological seals here. Only 7 minutes left. All right. So these are the tests that are used to assess the strength. It's called the push-out test. This is all done in vitro where they place the post in the tooth, they create discs, and then they put them on the Endostrom machine, and they see how much force it takes to push these out. They do this over a multitude of repeated steps to find out what are the bond strengths. Factors that affect these bond tests. There's a lot of things that go into this. That's why I'm saying the literature is not very clear on what we should do. Let's skip over that. But now we're going to get into what do we do? How do we treat the surface? And I love this analogy here. If you had a dog bowl, the schmutz that's on there is kind of like the smear layer. How do we remove the smear layer in restorative dentistry? Phosphoric acid. How does Todd remove the smear layer in endodontics? EDTA. So there's different chemicals that allow us to remove what I call the schmutz, which is just it's the biofilm that sits on top of the top of the tooth. Smear layers sometimes with some bonding agents are actually meant to be incorporated into the bonding process. So sometimes the smear layer is used. I would prefer the smear layer be removed personally. So the technique that we're going to talk about involves removing the smear layer. This is the smear layer. You can't see the open dental tubules, so you can't access the three-dimensional volume space that's here that you can see after you remove the smear layer. This is a conversation about re-wetting. Don't over-dry the surface. That's very important. How do you optimally dry a canal? I don't know. I mean, I have ideas, but I think that's what makes post-space cementation so difficult, where we're trying to bond to a surface that's so far from our ability to see, adequately treat, and that's why it's important to have very clear steps. I go into bond degradation. This is why I think most of the advertising in the adhesive world is misleading. The variable that matters is not how strong the bond is, the initial bond strength tests in vitro. That has very little relevance in clinical dentistry. There's only a handful of researchers out there that talk about how long does that bond last. It's a very interesting conversation that has to do with water absorption, MMP, so on and so forth. Happy to have the conversation if anybody's interested. Point being, chlorhexidine is a very good tool that slows down the breakdown of the hybrid layer through deactivation of the MMPs, are enzymes that we have in our own plasma. So our saliva contains these enzymes. They break down the exposed collagen that's associated with the hybrid layer. It's very important. If we can deactivate those, we should. So this is MMP, eats the collagen. Luckily, we have some tools that help fight Mr. Pac-Man, glutaraldehyde, chlorhexidine, HEMA, and maybe some other agents down the road. It's important to know that deactivation with chlorhexidine has been studied quite a bit, and it's a short-lived thing. So we're talking about how much integrity do you have in your bond in the hybrid layer at certain intervals after adhesion. If we use chlorhexidine, we buy ourselves about 12 months of delayed degradation of that bond layer. And those in the practice, you guys hear me talk about, I think, composite leaks all the time. This is what I'm talking about. There's a lot of studies using silver nitrate where they actually show microscopy that shows pretty much everything leaks. Not with enamel bonding, but with dentin or cementin bonding for sure. This is getting better now that we have MDP, stronger bonds now that we have covalent bonds. There's more hydrophobic natures to these bonding agents. The point is that once we place this in people's mouths, we tend to think that it's just going to stay there forever as long as they brush their teeth. In reality, that's not really the case. I don't place amalgam, but I still think amalgam wins in this particular category because amalgam doesn't leak. It actually corrodes and seals as part of the process. But enough with the science, let's get to the how. So there's two different methods that we can do. And I'm going to start with the simple method. Prepare the post space as described, try in the post, and then use a self-adhesive cement. This is what most people do. I don't think this is wrong. There was a doctor in the practice today. For one reason or another, this is what we went with. I do this sometimes. The literature does look at the difference between this method and the method I'm going to propose, and it's rather surprising that self-etch adhesive cements in post space actually do pretty well. Now, if you're going to use a self-etching cement to bond a crown on, those don't do well, and there's reasons for that. But I prefer this method here. This is what I call the "if it were my tooth, what would I do" method. So we prepare the post space as described, try in the post, and then we go through these steps here. This is complicated. There's a lot of potential room for error here. So if you're ever unsure about this process, just revert back to the simple method, which is prepare the post space, don't remove the smear layer, put in your Rely-X Unisem self-etch adhesive or GSEM. These are cements that etch the surface of the tooth as part of it. They have what are called acidic monomers built into the cement. It's a lot of chemistry going on in one material, which is why I don't like it. With that said, the literature is pretty clear. They do okay. The difference isn't very significant, but this is what I would like for a multitude of reasons. Most specifically, this is much more of a covalent bond than the self-etch adhesive method. So the first step is to remove the smear layer. You can use EDTA, 17%, 60-second soak. So you place it in just like you were doing the endo, but if you don't do a whole lot of endo, you probably don't have EDTA. In that case, you can use 5 seconds of phosphoric acid. Phosphoric acid is an etchant, meaning it removes the mineral component of the tooth structure for that micromechanical Velcro effect that we were just talking about. But if you only do it for 5 seconds, you don't remove the minerals. This has been studied. You only remove the smear layer. That's another way to remove the smear layer. Well, then you have this very viscous etch that's sitting inside the canal. So then you're going to follow through with water, rinse it out the best you can. You can use micro brushes to pull it out. There's micro cannulas. You really want to make sure that you get all that etch out before you move on, which is why I like following up with these next two steps, because it's additional steps to make sure that we're removing all of the etch, because etch has a high degree of effect on bonding if you leave any of that in there. So the first thing I'll do is I'll rinse with water, then I flush with 2% chlorhexidine. This is not Paradex. Paradex is 0.12%. 2% chlorhexidine is what we use in endodontics for retreatments because it kills E. faecalis. So it's a very relevant part to the endodontic world, but we use it in restorative dentistry because it deactivates MMPs, just like we talked about. So that's why we use that particular agent. But it's also another time to make sure that we remove the phosphoric acid. Then we follow through with alcohol. This is somewhat of an optional step, but it's another liquid to hopefully make sure that we thoroughly debride out the smear layer and any remnant phosphoric acid. But what's nice about ethanol is it has a high vapor pressure, meaning it evaporates very quickly. So if that's your final liquid going in the canal, you're more likely just to have a dry canal based on the fact that this stuff will find its way out very easily, as opposed to water and other aqueous solutions. Well, just to be sure, take some paper points, larger sizes the better, put them down, and I think we all know the mirror test, where you take the paper point and you take the point and you push down on the mirror. You can use your hand, but mirrors really give you a good sense. Is there any moisture left? If it's stiff and dry, they don't bend. If they're filled with moisture, they bend. So that gives you an idea. Is there still moisture left in that canal? We have, I don't know what they're called, those purple tips that attach to the surgical suctions. Some of the doctors like using those. I like using all of these. I want to make damn sure that's dry. But there is a conversation about we still need to have moisture to make sure that we have a hybrid layer that's somewhat moist. How you determine that moisture is very difficult, and it's why this particular protocol is very technique sensitive. I can't speak to exactly why, but I'll tell you what I do. After I've confirmed a dry canal, I take a paper point, I saturate it with 2% chlorhexidine, I push it in the canal, take it out, and then I put a vacuum suction over the top of it, and I just cross my fingers that that's the right amount of moisture. So far, I've never had a post come out. I have no doubt there's other ways to do it. That's just how we do it. Then I'll use a universal adhesive with MDP. By definition, a universal adhesive should have some form of MDP. But then air drying, it's very, very difficult because you're air drying, the surface area that you're air drying is very deep, and it's very possible that the apical portion, especially on the mandibular teeth, you have very significant pooling of the adhesive. So you really got to make sure you dry all that out. I sometimes use paper points to make sure I get all that out, and then I cure thoroughly. What's nice about universal adhesives, many of them come with dual cure activators, which is a very good way to do this. That's not what we do. I cure the heck out of it, and so far so good. I did 10 extracted teeth when I was putting this protocol back together several years ago, and I sectioned the apical extent, and I took an Explorer to make sure that I was actually cured down there, and I was, using the same lights that we use today. For those out there, we use the FlashMax P3, which is the strongest light on the market. It's 4,300 megawatts of energy. Very, very strong light. It cures what we need to cure. If you're using a halogen light, not sure that this would work. So if you're going to use an adhesive that requires light energy, be very cognizant of the fact that the deeper you go, the harder it might be to cure, which might advocate for the use of a self-etching adhesive, which has dual cure properties, which means it'll self-cure on its own. I hear somebody ruffling. Any questions or thoughts about this? The final is using Rely-X self-etching adhesive cement.
I've got a question.
Yeah, Steve.
How do you apply the, when you say rinse and dry with ETOH with alcohol, how do you apply the alcohol? It's just flooded in with cotton pellet or what?
Yeah, you could. We use a, Ultradent makes those scrub brush tips. They make a small diameter version of that. It's curved so it doesn't go all the way down the canal. But it's the same kind of tip you would use for Viscostat or Hemodent. It's a scrub brush. So we use that. There's probably better ways to deliver it, but at the end of the day, when we put alcohol anywhere near the canal, it dries a lot faster. I think it mixes with the water.
And on the micro syringe tips, I think you're referring to the, well, I don't know for sure, but I know that Ultradent makes some that have little micro adapters that you screw onto a suction adapter, white HVE suction adapter. They're purple.
Yep.
Extremely small. You can go to the very end of the root.
Yes, I have used those. They're kind of white, just like the regular. I know that's what you just said, but they're stiff and white, and then the tip of it's
purple.
Purple. Yep.
And why don't you just use a dual cure with your universal adhesive? Why do you insist on drying it and getting the light there?
Yeah, no, it's a great question, and it actually has to do with why I think this particular material here is better. So what Dr. Palmer is saying is, if we're going to use a dual cure cement, let me see if I have your question right. Why use a dual cure cement? Why use light curing bonding adhesives if we're going to use a dual cure cement? Is that the question?
Well, yeah, because don't some of the universal adhesives, don't they have a dual activator you can add to them to make them?
Correct. Yes.
It gives you a little bit of time. They don't set immediately, but.
Yep. Yeah.
And
So
then
what?
you can push your cement and then push your post right through it,
Right.
and not have to worry about getting your light as deep as all the way down.
Yep. The literature that went over that, so it's a great question, and it's somewhat hard to articulate without drawing some of the chemistry. What it comes down to is the simple fact that if that kind of chemistry worked really well, we would probably use that all of the time. So the bond strengths are weaker with dual cure activators.
I'd say.
So that's reason one. Reason number two, dual cure activators, there's something called tertiary amine incompatibility. I'm sure you've heard that term over the years. If you're using a specific system, if you're using 3M's system, you don't need to understand this chemistry at all. But if you decide to use one bonding agent with another, maybe that has a dual cure activator where the other one, the cement that you're using doesn't require that. When you have dual cure cements, the cement is very susceptible to pH changes. And as a result, in trying to simplify it, making sure that we don't ever run into that problem, we don't use dual cure activators. So that's an office decision that as we're trying to simplify it, I didn't want dual cure activators or dual cure cements for that matter, part of it if I could avoid it because of that incompatibility. Now, what we're trying to do is simplify it. So 3M being a company that I think is a leader in the world of the science behind the products that they use, I do think dual cure activators do play a role. But the pH component of it and how the chemistry is set in, there's much more micro leakage associated with those products. So light curing is always the best. The problem is, how do you know if you're getting all the way down? And that is a great question. So I think
the cement that you're using there is self-adhesive, so theoretically it would create its own adhesive bond, and you wouldn't necessarily need the strength of the Scotch bond universally.
Yeah.
Theoretically, although it may not be as strong.
And that's definitely been studied. If we look at the megapascal bond strengths of self-etching adhesive systems, whether it's a cement or adhesives, you'd be lucky to get 20 megapascals of strength out of those. So that's your initial bond strengths, whereas light curing adhesives, you're looking at 40, 50, 60 newtons, not newton centimeters, but megapascals.
I see.
But the real reason, that difference, is it clinically relevant or not? Maybe, maybe not. But when you look at the self-etching and self-adhesive systems, they break down over time a lot faster than light curing materials.
I see.
And if you think about like veneer cements, why is a veneer cement 100% light curable? Because of that reason. They're more stable. Yes, the materials have gotten better over time, but Steve, I think you probably remember there was a time you were not putting a veneer on with dual cure cement or a self-curing cement. It was 100% light curing. And that has to do with the chemistry and the pH of the materials. They've gotten better, but as they've gotten better, the bond strengths have dropped. It's kind of that old adage of the old materials are still better. So there's a lot of complexity that comes to the decision making here, and I do think maybe we're oversimplifying it, but I want people to understand that this is complex. You can simplify it, but you're sacrificing a little bit of bond strength, sometimes a lot of bond strength. The difference between the protocol that I have, which came from different aspects of the literature compared to just using a self-etch adhesive, it's pretty significant. What I will say is this product right here, so I want to end on this. This is a new cement from 3M, and the chemistry involved with this product fixed the whole idea of the bond degradation. So I actually wanted to spend a lot of time talking about this, but I think the chemistry will probably bore people. Out of the box, reading the in-package literature, and there's 3 articles that I read that were done in the past 5 years on this product that were not sponsored by 3M, were very promising about this material. And the reason is there's a very specific chemical reaction that occurs over time where the pH of the the hybrid layer actually improves. It's the first material, and it has to do with how they manufactured the product. So I think this particular material might be the first material that we can use without all the fancy etching, the fancy protocol that we just went over, and get really good bond strengths, maybe not as high, but clinically good enough without bond degradation. More to talk about this product. So any other thoughts, questions?
If this is too long to get into right now, we can talk about this later, but I know you've talked about Scotch Bond and All Bond. Can you simply get into the difference between, like, I don't know, are they equivalent to you, like one versus the other? Because in our protocol, it's specifically says All Bond, but then I guess some people have been using Scotch Bond, and you obviously just mentioned Scotch Bond was fine, so.
Yeah. So in our office, that's Dr. Mender, Elena Mender, she works in our office, and we use both Universal Bond from Bisco and Scotch Bond Universal. They're both universal bonding agents. They both contain MDP. The reason why when I did that protocol I chose Universal or All Bond from Bisco, it is the most compatible universal bonding agent. So there were some studies done where they mixed a bunch of chemicals together and they said which one is most likely to produce bond strengths above this level, but also be conducive with any material that's out there. And Universal Bond was the leader there. So that's why I decided to do that. And the reason is, over the years, I have associates that go to conferences and they see a material and they have to use that damn material. That's why I'm trying to create something that kind of crosses all the different manufacturers. I'm not going to tell everybody what to do just because I think I'm right. I want people to try different products because sometimes those products are superior. But if they're not following all of the nitty-gritty chemistry underlying it, then we run into problems, and there's very, very significant problems that occur if the pHs of the materials that you're using don't align or they're not compatible. So the Universal Bond we use for that purpose. We also had Scotch Bond because Spear, a lot of us are Spear trained, they advocate for the use of it, so we had to have that material too. So that's why we have the two bonding agents. All of the materials we have in the office right now, you can use either of those adhesives. I'll simplify that answer. You and I can dive deeper into it if you want. I think ultimately we're going to get rid of the Universal Bond. I think I just want to streamline things and go maybe with 3M. There's a few other studies I want to read that talk about that particular decision. But trying to keep it simple, but I want us to still at least think about what's going on chemically with these materials, because I think our patients deserve that we understand this stuff so that we're making good decisions. Maybe not understanding the granular nature of tertiary amines, but at least having a basic understanding, or read the directions. I mean, that it sounds so simple, but it's just not done. As somebody who's visited many offices over the years, for one reason or another, I am astounded at some of the product interactions that many clinicians have in their practice, and they have no idea what is actually happening. So let's have a conversation about what those potential things are, and let's make good decisions.
Thank you.
Yeah. All right. Todd, any last notes from the endo perspective?
I think the only thing I would add that you haven't really touched on is just when we're considering posts, the really the most important thing to consider if we're putting a crown on top of a broken down tooth is to make sure that you get a good ferrule.
Yeah.
I think that alone probably outweighs any benefit you're going to get from a post. So that would be king. And then a post might just be belt and suspenders. I do place a lot of posts. If I'm going through a crown, 9 times out of 10, I'm placing a post, but I'm doing it in a way that is conservative, and I'm just trying to prevent crown fracture afterwards. So I do advocate for posts in considering not removing too much tooth structure, just as you had alluded to previously.
Yeah, I love what you said, that the biomechanical aspect of the coronal part of the crown is a very significant part. And I think we're going to dive into that because I think it deserves its own conversation. I remember Dan Armstrong once asking me the question, is a ferrule important 360 degrees around a tooth? Or does it matter if it's on the buccal and lingual or the mesial and distal? And it was like, that's an interesting question. So he gave me some articles and I read them. There's a lot there. It's not just, it's not easy to say whether or not that tooth is restorable or not. It's a very, very complex question. Every dentist has their opinion on it, but the literature is pretty clear, like you're saying, that the ferrule is really the most important factor, even with these flexible posts, because what happens if you don't have a ferrule is micro leakage through percolation. And again, that's more of the biomechanical part of the conversation, which I think we should have in a couple of weeks. But I think your point, Todd, is very well received in the fact that we have to make sure that we have that foundation in place. And if we don't, we go get it. We extrude the tooth orthodontically. We do crown lengthening. There's different ways of getting it. We don't need to pull teeth every time just because implants are quote unquote better. Implants are not better. Implants are great replacements of teeth. They're good replacements for missing teeth, but they're not necessarily good replacements for teeth that could be salvageable. It's a very important distinction as we're starting to see the advent of peri-implantitis increase in the profession. We're starting to realize that implants aren't the golden ticket that we thought they once were. They're great, but if we have a tooth that we can restore, we should explore those options, and that's what we're doing here. So on that note, unless anybody has anything else, I will sign off for tonight. Happy 2023, everybody. And if there's any topics that anybody wants to go over, love to hear what people want to chat about. If there's any specialists that you think would bring some special value to our conversations, would love to do it. I think having Todd here the past few times has been super helpful to know his perspective, because he is practicing in a world that we don't see every day. So there's perspective there that is of high value. So anybody else?
Thank you very much.
All right.
Thanks, Dr. Mellon.
Thank you.
Thank you, Dr. Mellon. Have a good night, everybody.
Thanks,
Thank
Nick.
you.